All right, okay, ayan. So hello and hello dears. Hello and good day, no? So wala ko kabalo kung what time of the day ninyo siya lang tawag ni. But anyway, good day, hello and welcome to the continuation on our lecture on the second part of urinalysis, which is again your chemical examination of urine. All right, okay. So for the second part, which is your chemical exam, all right, we have already began, no? Sa atong synchronous session yesterday, okay, on the first two parameters, no, of your chemical examination, which were specific gravity and pH, all right? And because again, medyo holiday, no, holiday tayo ngayon because of the fiesta sa Dumaguete, no, today and tomorrow, 24-35. So mag-pre-record lang sa ta, all right? So we're going to finish, hopefully, good ang chemical exam, mahumana dyan nato na siya, all right? Para immediately right after finishing chemical exam, we'll proceed to your microscopic exam. All right. So again, we have already started, as I mentioned, with the first two parameters. You have specific gravity and pH. All right. And we have discussed na thoroughly, hopefully, the different methods, no, and principles, clinical significances of these two parameters. All right. So I hope medyo clear lang to siya. All right. For this lecture, we're going now to continue, and for this part, we're going to start with protein. All right. Now, protein, ayan, protein na. All right. Protein, among all the parameters of your reagent strip, this is considered to be the most indicative of your renal disease. Of course naman, because in normal urine dears, there should be no protein or only little amounts of protein. Ayan. And the presence of this protein or the presence of protein in urine really signifies, no, a clinical disease, no, or a clinical manifestation of a disease. And usually this is indicative of renal disease. So among tanan-tanan yun, the reagent strip parameters, it's the protein that can indicate renal disease. Okay, all right. Now, we have discussed this in physical exam, no? In large amounts of protein, no? Large amounts of protein, it can cause the production of a white foam. And this white foam is again large food in appearance, and it is long-standing, all right? Or it will predominate, or it will last long, okay? It's long-standing or long-lasting imuhang foam, na white foam, all right? Okay. Now, normal, of course, as I mentioned, urine has a normal amount of protein, pero little lang yun siya, all right? The normal amount is about less than 10 mg per dl or less than 100 mg per 24 hours. So as you can see, medyo gamay ra gyud siya, all right? And the major protein, serum protein found in urine is your albumin. Now, you may be thinking, di ba, we have mentioned in renal function that your albumin, although it is really filterable, because again, a molecular weight ni albumin is 69,000 Daltons, dears, di ba? So it's still well below, no, less than, it's well below 70,000. So pwede pagyud kaayo jud siya na ma-filter sa glomerulus. But because of this structure sa glomerulus known as the shield of negativity, or the overall charge of your glomerular filter is negative, iyahang ginarepel ang imuhang albumin. So thankfully dili siya makasulod or ma-appeal sa filtrate, but nadya po ginagmay yun na makalusot, alright? But this albumin, gyapon na makalusot, it is also reabsorbed in the tubules, alright? Pero kung di gyapon siya ma-appeal sa reabsorption, it can appear in urine, pero in little amounts ra yun, alright? That is normal. Now, usually in normal urine, the protein, kung positive man gani, or the normal amount of protein found in urine is composed of course, 1/3 albumin, 1/3 lang albumin, 2/3 sa mga globulins. Kinsa man ang mga globulins, the rest, no, which is your, again, mga serum and tubular microglobulins, tam horseful protein, urokinase, and proteins derived from prostate and vaginal secretions. All right, so kanis lang yun ang majority mag-make up sa proteins found in your urine. All right, 1/3 lang albumin, because again of the reason that albumin cannot be filtered by your glomerulus, silang tanan yun, because again of the shield of negativity. All right, so if ang protein, normal protein in urine, ang mo-constitute yun na majority is globulin, pero the major serum protein found in urine is of course albumin. Now, normal values for Henry, it's less than 150 mg per day, and for Strassinger, it's less than 100 mg per day, or less than 10 mg per dl. So, siya dyan ang major protein. Now, the other proteins kinsa gani pwede, as we mentioned, mga globulins na. You have serum and tubular microglobulins, which are again produced by the tubules and gikan pud sa serum. Example of that is of course your secretory IgA, no? There are secretory IgA released by the tubular epithelial cells, which can be expressed also in urine. All right. Number two is, of course, tam-horsefall protein or your uromodulin. Okay. And of course, in the microscopic exam, we will encounter this again. Of course, the tam-horsefall protein or uromodulin is the major constituent of your mucous threads and the casts. All right. Sa ibang mga sediments sa urine. So later, when we go to the microscopic exam. All right. Of course, urokinase, which is an enzyme secreted also by your tubular cells, which has a fibrinolytic function. So it destroys or it disintegrates the fibrinogen. No. So it's a fibrinolytic enzyme. So it's included in the coagulation cascade, coagulation function, actually coagulation function. All right. Or fibrinolytic function. All right. So yeah, this is familiar. I remember this sa HEMA. I think I discussed this. So, ayan, pasensya na again. Hima, medyo weak tayo dyan. Okay. Sorry naman, all right? And of course, not only proteins derived from the kidneys mismo or from the serum or plasma in the body, there are also proteins that are secreted by the vagina or prostate that can also be introduced in urine and urine. So, daghan yung kayang possible proteins na ma-include. But among them, ang pinaka-clinically significant or the major talaga na protein that could indicate a renal disease is your albumin. All right, and clinical proteinuria, which is proteinuria that is very much indicative na of disease, kung ang iyahang levels is greater than equal 30 mg per dl or 300 mg per liter. So if inani na ang levels ng muhang protein, then of course that is indicative na of possible disease, no? Especially renal disease. All right, okay. Now we go now to the different clinical significances of your protein. All right. Now your proteinuria, when you say proteinuria, is of course the appearance, no, of protein and ihe. Proteinuria, ayan, muna nasa pangalan na. All right. And okay, tama. So proteinuria again is classified into four actually, no? Pero three lang na diri. You have the pre-renal, renal, which ang renal pwede siyang glomerular or tubular, and lastly you have the post-renal. So nasa pangalan na mismo actually, you already know kung unsay mga cause niya. So when you say pre-renal, nasa pangalan na before the kidneys, no? Other names of course of overflow, all right? So when you say overflow or pre-renal, these are conditions, no, in the body or in the plasma, all right, that contribute to increased proteins, all right, before reaching the kidneys, all right. And usually these diseases are those that produce or are related to mga infection or inflammation and even intravascular hemolysis, because in these disease states or mga conditions, they produce increased amounts of protein, all right. And that's why it's called overflow, no, because overflow, because of their increased amounts, no, increased amounts of these proteins secreted by these specific diseases, no, ni overflow siya, no, too much siya kayo na produce na protein maong na produce or na appeal siya sa ihik, no, the amounts of protein released exceeded the tubular reabsorptive capacity of your tubules. That's why they are expressed in the urine. Muna siya ni overflow, no, ni lapaw, ni sobra, ayan, because too much production of these proteins, all right? And what are these conditions that can exhibit pre-renal proteinuria? Of course, number one, you have intravascular hemolysis. So we say intravascular hemolysis, of course, the lysis of RBCs within the blood vessels, all right? So they, of course, release hemoglobin. And hemoglobin is a protein, all right? And it can be expressed in urine. Number two is, of course, muscle injury, which releases myoglobin, rhabdomyolysis, all right? Severe infection and inflammation, of course, because there's an increase in your APRs, all right? So what do you mean by APRs? Acute phase reactants. And these acute phase reactants will be increased primarily during infection states or inflammation ng mga diseases, all right? So muna siyang mo-increase iyahang levels. Again, APRs, example, you have mga alpha, katumang alpha-1, antitrypsin, CRP, of course, APR, mga serum amyloid A, etc. So kana sila tanan mo increase during inflammation. But of course, CRP is the most important, the most significant talaga na marker for inflammation. All right? Diba albumin then? Albumin, is it an APR? Yes. Pero is it a positive or negative APR? Naku, dapat na-answer na to. Back tayo sa clean chem dyan, okay? Is albumin an APR? Yes, pero is it a positive or a negative APR? It is a negative APR, meaning during inflammation, the albumin levels in the body decreases. All right, so ang positive APR, sila ang mo increase during inflammation, ang negative sila ang mo decrease. And one of that is, of course, albumin ang negative. Gamay ra ang negative na APR. I think it's only albumin and pre-albumin and transferrin ba? Basta I forgot. Basta albumin is one of the negative APRs. The rest kay positive APRs na. Alright? Ayan. So, during severe infection inflammation, it can lead to pre-renal proteinuria because again of increased APRs. And of course, a very important, multiple myeloma. Of course, alam niyo na yan. Multiple myeloma is a type of neoplasm and kinsa man ang kinsa ng mga ni proliferate. It's the Ig antibody producing ng mga plasma cells. And they produce, of course, mga defective antibodies, no, in the form of what we call your Benz-Jones protein, of course. So this Benz-Jones protein, medyo daghan kayo na-produce imuhang plasma cells, of course, because it's a neoplasm. So it's a neoplasm, uncontrolled, no? Uncontrolled ilahang production, uncontrolled ilahang pagdami, pag-proliferate. That's why ang ilang gina-produce na mga antibodies or mga proteins are also defective because daghan na kayo sila, wala na na-control maayo ang paggama sa cell. So ang possible na na-produce na cell kay mga daot pod. So ang gina-produce po sila nila ng mga proteins, in this case Benz-Jones protein, it's also defective, all right? And Benz-Jones protein is of course is actually a defective antibody, no, immunoglobulin, because ang naa niya kay duha ka light chains. Nako, balik tayo sa IS. Ayan, nako, IS talaga. Okay, so ako wala sa nakibutan ako whiteboard years kasi alam niyo na yung pwedeng mangyari. Okay, baka pwede siyang matangtang. Di ba remember the normal structure of your antibody, na siya heavy chains and light chain. Alright, now this is the normal, sorry. Ang pangit ng drawing, wait. Okay, ano na lang, ayan. So these are the heavy chains and diba, these are the light chains. Now as you can see, diba, it's very, muna siya ang original talaga, the normal structure of the antibody. So you have the light chain here, diba, and the heavy chains, kani siya, heavy chains, no? So ang normal binding is light to heavy and heavy to heavy, alright? Pero walay light to light, okay? And kaning light to light na binding, that is your Benz-Jones protein. So may tabo, kanina ma-produce light chain and kaning duha ka light chain and nag-bind sila. Ayan, so inana yung appearance, parang ganun. And that's your Benz-Jones protein. And that is a defective or abnormal na immunoglobulin, alright? Now these Benz-Jones protein, again, it is increased in states of neoplasm, such as especially your multiple myeloma. Alright. Now, some very important characteristics sa imuhang Benz-Jones protein. It can be released in urine. And very important in patients with multiple myeloma, ilang ihi, mahimong, cloudy, ayan, or turbid at 40 to 60 degrees Celsius. But, pagsaka sa 100 degrees Celsius, mahimo siyang clear. Why? Because again, of the presence of Benz-Jones protein. Because ang imong capabilities imong Benz-Jones protein or yung characteristic is it is insoluble or precipitate siya at 40 to 60 degrees Celsius. But if you increase the temperature at 100 degrees Celsius, mahimo siyang soluble. That's why ma-clear na siya. Ma-clear mo ang specimen at 100 degrees Celsius. Now, interference of other precipitated proteins can be removed by filtering the specimen at 100 degrees Celsius because the rest of your normal proteins or other proteins, they will precipitate at 100 degrees Celsius. So, pag examine mo sa specimen, if mo precipitate, if ma-cloudy siya at 100 degrees Celsius, then that's possibly due to the presence of other proteins aside from Benz-Jones protein. Now, if you want to only detect Benz-Jones protein, i-filter ni mo yung specimen at 100 degrees Celsius because again, katong mga precipitated na materials dito are the other proteins. So pag filter ni mo, katong remaining na supernatant or fluid, ang mabili na lang dito is the Benz-Jones protein. So after 100 degrees Celsius, ipa-cool na po ni mo specimen to 40 to 60 degrees Celsius. And if mo cloudy na siya, alright, then you are sure na ang cause sa cloudiness or turbidity sa imong specimen at that temperature, 40 to 60 degrees Celsius, is your Benz-Jones protein. Alright, but of course, this is just one of the supplementary tests. It's not usually definitive, especially for multiple myeloma, all right? Because for multiple myeloma, the best test to perform is of course electrophoresis. Your immunoelectrophoresis or serum electrophoresis, all right? That's the best good na test. Your kaning characteristics sa urine, that is just supplementary, all right? But if you really want to diagnose multiple myeloma, you don't rely on the urine or the Benz-Jones protein appearance sa ihi, but you perform serum electrophoresis, immunofixation electrophoresis. So mga immunological tests. All right. So that's for pre-renal. Ayan. So again, before the kidneys na naanay increase in proteins. All right. So pag-abot sa kidneys, because increase man yung amounts of protein, may expression sa ihi because again, the amounts of proteins have reached the tubular reabsorptive capacity of the tubules. All right, okay, that's pre-renal. Next, of course, is your renal proteinuria. When say renal proteinuria, it's really affected, or the cause of proteinuria is due or it's because of a damage na yun sa kidneys mismo. And your renal proteinuria can be divided into two major types. You have glomerular and tubular proteinuria. So we'll start first with glomerular proteinuria. So nasa pangalan na, glomerular proteinuria, it's proteinuria caused by or is because of the damage in your glomerulus. All right, and your glomerular proteinuria is considered to be the most serious and the most common. Of course, because again, there is already destruction of the glomerulus. All right. Okay. Okay. All right. Sige. Now, very important disease na lang talaga that can cause damage, no? Or what are the causes talaga ngano magubay mo ang glomerulus? Of course, if toxic substances can be introduced to the kidneys, no? Such as mga heavy metals nor other agents. Aside from that, mga amyloid substances, no? Breakdown products in your body, and of course, another is your immune complexes brought about by different diseases, especially due to streptococcus infection, diba? From your throat, diba? Remember, one of the important sequelae or complications of streptococcus pyogenes infection from the throat is acute glomerulonephritis. And unsay pathophysiology, ana, there are immune complexes deposited in your glomerulus. And these immune complexes will trigger complement fixation, and mato ang mga complement or ma-trigger ang complement system dito, all right, which ultimately cause damage to your glomerulus, which can lead to glomerulonephritis. All right, so those are some of the diseases that can cause glomerular damage. Another one is, of course, diabetes. All right, so the mechanism as to why there is glomerular damage for diabetes is still not known kaayo, pero one of the postulates or one of the accepted explanation is that your glucose at high concentration, because of high glucose, the glucose will bind, no, to the proteins found in your glomerulus, and this will lead to changes in the glomerulus and proliferation also of the cells in glomerulus, which can lead to defective cells and eventually damage to the glomerulus. All right, so that's another complication due to diabetes. That's why it's very important good for diabetic patients to monitor good their sugar, and aside from that, their protein level. Later, when we go to microalbuminuria, we'll discuss that, diba? Because it's important, no? One of the complications good of diabetes, which can be deadly, is diabetic nephropathy. So, ma-include or ma-involve yung kidneys. Now, your diabetic nephropathy, again, decreased glomerular filtration, all right? Because again, there's a damage in the glomerulus, so medyo magliso na siya filter. It may lead to renal failure, of course, in the long run, and indicators, of course, microalbuminuria, as I've mentioned. We say microalbuminuria, lower, small amounts, no, or small concentration of albumin in ihe, microalbuminuria, all right? And because it's only little, all right, it's the proteinuria undetectable by the reagent strip. Because again, the concentration is still little. Ang imong albumin, little pa lang iyahang concentration to be detected by the reagent strip. That's why it's called microalbuminuria. All right, okay. Now, before testing or in the past, no, wala pa yung microalbuminuria ng mga tests. In order to determine this microalbuminuria or the level of albumin secreted or excreted by the patient, especially patients with diabetes, no, they monitor or they measure what we call the albumin excretion rate, all right? Your AER. Now, this AER, again, uses 24-hour urine. So imagine, no, 24-hour urine, because again, it measures the amount of albumin released in a day, no, or 24 hours or per minute, all right? So that's their way of measuring, no, or monitoring the amount of albumin secreted, especially in patients with diabetes before the development of tests for microalbumin. All right. So for normal AER, the normal is 0 to 20 UG micrograms of albumin per minute. For microalbuminuria, this is now considered to be the little lang levels of albumin secreted. If 20 to 200 micrograms per minute or 30 to 300 milligrams per 24 hours ang release, and clinical albuminuria na good, meaning nanadyoy damage sa imuhang glomerulus, nanadyoy disease, no, if it's greater than 200 micrograms per minute. So this is considered to be kato mga initial tests, no, before the development of other tests for microalbumin, such as the micral, immunodip na mga tests, no. So albumin excretion rate mo na lang gi-device, no, or gibuhat og una to determine the amount of albumin secreted in a day, okay, especially seen or especially performed in patients with diabetes. All right. Now, what are the major proteins in glomerular proteinuria, dear? So this is from Brunzel. So you have albumin with a major, but aside from that, you can also see transferrin. You can also see alpha-1 antitrypsin and alpha-1 acid glycoprotein. So these proteins, magod, generally, sila ni mga proteins na dili dapat ma-include sa filtrate because they are repelled by the shield of negativity, or they're also larger, no, in molecular weight or in Daltons, all right? But in glomerular disease, again, or glomerular damage, wala na tong shield negativity, or dili na siya ka-selectively filter, meaning dili na niya ma-filter itong mga dagko na mga substances greater than 70,000, so mo-appear na sila. So kanina sila ng mga proteins, albumin, transferrin, kapto sila ang normally good na dili ma-filter. Because again, of their weight ba or the shield negativity. But in glomerular damage, wala na itong shield negativity, or dili na po siya ka-selectively filter sa mga dagko na mga molecular weight substances, maong mo appear na sila sa imuhang urine. Alright? So major proteins and glomerular proteinuria. Take note of that, no? Baka lumabas, dears. In the future, no, sa inyong boards and other exams. Very important. That's from Brunzel. Now, another type of proteinuria, dears, under renal lang, is functional proteinurias. Now, these functional proteinurias are just actually, di siya pathologic. In a way, it's not related to kidney disease. Ayan. It's not related to kidney damage, but because of other conditions that contribute to this. No? And these functional proteinurias can be glomerular or mixed, meaning mixed glomerular or mixed glomerular and tubular. No? So it could be glomerular or glomerular and tubular. All right? And again, walay problema sa kidneys, all right? It is due lang to other diseases, no? Such as hypertension, okay? Such as hypertension, such as fever, exercise also, emotional distress, congestive heart failure, and dehydration. And actually, apil po si orthostatic proteinuria. Wala yung problema sa kidneys, pero because of mga changes in the body, changes in pressure, no? Changes in renal blood flow or whatever, dito siya makaproduce of proteins or ma-express niya ang protein sa ihi. That's why makitaan ang proteins or ma-detect ang proteins sa ihi. Alright? So those are termed functional proteinurias. Alright? So, pero wala problema ang kidneys. Okay lang. Alright? Ayan, sige. Now, that's for the first type, no? Your glomerular proteinuria. Alright? Now, we go now to the different tests, no, for microalbumin. Because again, di ba, microalbumin is one of the important yun na mga tests or detection for diabetic nephropathy. And sure enough, no, microalbuminuria, or as we have mentioned na, di ba, sa una sa ClinChem pa lang, microalbuminuria is one of the earlier, no, or if not the earliest indication yun of involvement of the kidneys in patients with diabetes, no? Or earliest indication of diabetic nephropathy yun is microalbuminuria, all right? And when you say again microalbuminuria, it's the excretion of albumin in little amounts, no, in the urine. All right. Now there are now again recent, no, na mga tests, recent tests that are already formulated for the detection of this microalbumin. And as I mentioned, diba, before these tests, ang ilahang ginabuhat is the albumin excretion rate, which uses 24-hour urine. And because of the hassle, no, or an inconvenience of collecting 24 hours of urine, that's why they thought of formulating and using other tests and to detect microalbumin. And the first is, of course, the micral or micral test. Your micral test is, of course, it's immunochromatographic. Immunochromatographic test. This is immunochromatography pala. Enzyme immunoassay. All right. Pero it uses a strip. Ayan. It uses a strip. And it follows the principle of immunochromatography, actually. Labeled immunoassay, no? It uses a labeled antibody, no? Antibody, anti-human albumin that is conjugated with a gold, no? So it's a gold conjugate antibody to albumin, all right? And it uses the enzyme beta-galactosidase and the substrate chlorophenol red galactoside, all right? So diri siya magsugod, dears, imuhang sample, ayan. So it will go there, all right? So there is a detection zone, there is a zone 1. The albumin, if present, will bind to the antibody, all right? Ayan, sa ako nag-draw. So albumin, example, albumin is siya, dears, all right? And then you have here the antibody to albumin na labeled with an enzyme. Ako na butang enzyme, all right? So of course, pagbutan mo sa sample, mo combine siya with here, ayan, combine siya diri. Of course, the flow is padulong diri. And then there is a detection zone or detection pad, all right? Nadira ang chlorophenol red galactoside na substrate. So kato mga na-bind nimo na enzyme, of course, it will combine with your chlorophenol na substrate to form the color reaction, all right? The color of the line, okay? And that is what is detected, okay? All right, so sensitivity, again, pila 0 to 10 mg per dl. And false negative is, of course, dilute urine, all right? Because again, when you say dilute ang urine, meaning gamay po ang protein sa naa. So it can affect your detection because gamay ang urine na naa. So false negative kay diluted man ang urine. Gamay ang protein na fat na naa because of diluted state of urine. Okay? All right, ayan. So that's for the micral test. So it's actually a immunological test, no? It uses a strip enzyme immunoassay ang imuhang principle. Okay. So that's for the micral test. So the possible colors ranging from white to red. So ang red ang positive. Okay. And the amount of color is directly proportional excuse me, to the amount of albumin present in urine. So if red good siya, if strong yun yung color na red, then it indicates medyo taas ang albumin na na. Alright. And the color is compared to a color chart sa imuhang bottle, no? Or color chart provided by the manufacturer after 1 minute. Okay, after 1 minute. Take note of that. Alright, that's for the micral test. Another one is what we call the immunodip. Sorry. Ito pa pala. Micral test procedure, pasensya. So, i-dip lang yun siya, and then you wait for the reaction to happen, and then check for the color result. Ayan. So, as you can see, di ba? White to red. Ayan. White to red. Okay. So, ang red yun, it indicates greater amount. Okay. Greater amount yun of albumin present. Okay. The next procedure is, of course, your immunodip. So, same regapon, dear. Your immunodip is actually same principle in a way with your with your micro test. But this time, this is an immunochromatographic test, meaning na siya sa, gi-house siya sa test kit. Okay, so it's a test kit. Sensitivity is 1.228 mg per dl. The reagent still uses antibody-coated blue latex particles. And same interferences, false negative is dilute urine. Why? Because kung dilute ang urine, medyo gamay na lang ang proteins na naa or albumin, so medyo dili siya ma-detect, so ma-false negative. So here is the illustration, all right? So, inani ang picture niya, dears. Feline ni siya, so para sa cat, no? Pero inani po para sa humans, okay? But anyway, so imo na siya i-dip, muna siya imong sample with urine, okay? And diri mag-start, no? Or diri mo sulod ang imuhang urine, and then the flow is pasaka, okay? All right. Now here, as you can see, medyo na yung mga illustrations diri, ato lang i-explain light. So as you can see, dears, no? Kani mga circle here is the albumin, no? Found in your urine, okay? Now, as you can see, diri pa lang daan sa vent hole or sa sample entrance hole. You can already see kaning square and kaning antibody. That's the antibody conjugate, all right? Blue conjugate na mga latex particles. So, it has an antibody, all right? Antibody and the enzyme na naka-attach to it, okay? Now, of course, kani sila mo bind with albumin, okay? If albumin is present. Sorry. Ayan. If albumin is present. Now, in the first band, of course, ang nasa first band, as you can see, are mga immobilized na human serum albumin. So, dili pa lang sa band 1, dears, na reagent, na ay mga serum albumin na naa. Okay? And this will bind to the unbound na mga conjugates diri. Kato mga wala na bind sa albumin. Okay? So, kani siya, alright, i-capture ni siya diri sa band 1, sa first band, okay, sa imuhang reagent na serum albumin. So reagent siya mismo na meaning naa siya sa imuhang kit daan, okay? So sa band 1 kani siya na ay immobilized na mga albumin particles dito, alright? And what's say purpose? It will capture the unbound, okay? Unbound na kani mga conjugate diri sa ilalom na wala nakabind sa imong albumin na naa sa ihi. Okay? Alright. So, pag mabind na to siya, katong mga already bound, okay, daming words, no? Baka malito. Anyway, so katong mga nakabind na daan, meaning, diri pa lang daan na bind na siya albumin, sila ang mo-add to diri sa second band, okay? And in the second band, it has the capture antibody, okay, that will capture your substrate, okay? And this conjugate or substrate, okay, sila na produce of color, all right? which now signifies a positive result. So, imo i-compare ang duha ka bands, no? Ang upper band, it will signify the albumin coming from the sample, And kaning sa ilalom na band, it's for control purposes. Okay? So imo i-check ang imuhang taas. Ang imuhang taas gud na band imuhang lantawon. Alright? So again, ang purpose ana is albumin dears kaning mga circle, okay? It will bind to your reagent here. Okay? It will bind your reagent here. So sa man reagent, blue conjugate. Blue latex particles na naay antibody to albumin. Okay? Alright. Now, of course, gikan pa lang diri dears, if nanay albumin imuhang patient sample, mo bind na sila diri sa imuhang reagent. Okay? So, of course, they will move upwards. Alright. Now, the first band, unsay gani ang kuwaon niya, kato mga unbound. Okay? Kating mga inani na wala nakabind sa albumin. Okay? Alright, gikan sa imong sample. So, kuwaon siya diri. Kuwaon siya diri sa imong first band. And kaning first band, it contains already immobilized na serum albumin, or meaning immobilized na albumin particles. So it's really part of the kit. So reagent yun siya mismo. Alright? Again, band 1, it contains immobilized, meaning nakapundo ra siya dito ng mga albumin. Ano siyang purpose? Iyahang dakpon. I-capture niya itong mga unbound na conjugate diri sa ilalom na wala na bind sa imuhang albumin found in the patient sample. So I hope na-gets to siya. Alright. Now, of course, diri pa lang daan kabantay mo na may mga blue conjugate na nakabind na sa imuhang albumin gikan sa patient. So kani sila mo padayon og saka padulong diri sa second band. And in the second band, you can see na capture antibody. And this capture antibody will capture, nasa pangalan na, katong nakabind na conjugate and albumin gikan diri sa ilalom from the patient sample. Alright? So, kato siya, diri sa ilalom, mo bind diri sa imuhang antibody conjugate diri sa second band, and this will now detect the albumin found in the patient sample. So, in a nutshell, katong sa taas na band, siya ang mo signify sa imuhang presence sa albumin sa patient sample. And the first band is for control purposes lang. Alright? So, therefore, for results, ayan, so I hope nag-guess na to siya, dears. Munang lisod jud medyo challenging i-explain ang mga IS concepts, pero sana naman nag-gets lang. So, for the result, as you can see, diba, the first band is for control purposes, and the second band is for for detection again of the presence of albumin sa imong sample. So, therefore, if mas darker ang color sa band sa taas, meaning mas daghang albumin na na-capture or na-bind. Alright? So, therefore, if darker ang top band, as you can see, mas taas ang albumin. Alright? Kung equal band colors, medyo borderline lang. And kung darker ang bottom band, darker ang bottom band, okay, which is the control, meaning less lang ang albumin na naasa mo ang patient. So I hope na-gets lang to siya ha, ang principle. Actually, medyo carry naman ang drawing if medyo naglibog pa. But anyway, muna siya yung point. Alright? Ang taas na band, okay, the top band, siya yun ang mo signify if the patient sample really has albumin or wala. Okay? Alright, ayan. So that's for the immunodip. So immunochromatography yapon siya. Alright? Na principle. Whew, I hope na-get lang to siya, dears. Sana naman nakasabot ra sa explanation. Okay. Alright. Next, you have your the albumin-creatinine ratio. Ayan. So the albumin-creatinine ratio, some of your strips already, ang ginadetect ra kay albumin and apil ng creatinine, no? So the principle here is sensitive albumin tests. They relate to creatinine measurement to correct for patient hydration. Because remember that creatinine is secreted at a constant rate, no? Bahalag kinsa man na siya, no? Constant rate ang secretion sa creatinine. Whereas your albumin is affected by hydration. So for us to correct the differences in hydration, ato siyang i-compare sa creatinine, which is constantly produced. So para at least, if ever, unsa mga ni results sa albumin, mapataas man na siya or mapagamay, kabalo ka na it's not affected by hydration because you compare it to creatinine, which is not affected by the level of hydration because it's constantly produced, okay? Alright, by the body. Ayan, so therefore, makabalo ka na, okay, kani akong results sa albumin, it's not affected by hydration, okay? Kay, it's corrected na diyan. It's corrected na by the hydration. It's corrected by the hydration practices of your patient. Okay? Alright, so that's why na siya creatinine. Ano siya i-compare sa creatinine. Alright. Now, the reagents for albumin, of course, medyo mataas, pero tetrabromosulfonphthalate, you remember. Creatinine, you have copper sulfate, tetramethylbenzidine, and diisopropyl benzene dihydroperoxide. Alright. Now, for sensitivity, of course, you have albumin 10 to 150 mg per liter. Creatinine is 10 to 300 mg per dl. Interference is, of course, visibly bloody or abnormally colored the urine because it can mask the color reactions. And for creatinine, it's cimetidine, which can lead to false positive. It's a medication. Now, the principle of your creatinine, dears, it's copper sulfate, pseudoperoxidase activity of the copper creatinine complex. So what happens is sa urine, ang creatinine na found sa urine, it will bind to copper sulfate to produce the copper creatinine complex. And this copper creatinine complex, same siya sa principle sa imong blood na pseudoperoxidase, it will catalyze the reaction. It will become the peroxide, no? At the peroxidase, it will catalyze the reaction of your kaning peroxide, no? Yung bulagon. And what happens is ma-oxidize imuhang chromogen, which is tetramethylbenzidine, which then produces the color. Okay, so napo na siya sa strass, pero ako siyang wala ko siya include here, pero nasa strassinger. So again, copper, no? Ako na lang i-drawing siguro para mas mag-gets. Okay. Wala din ako na-include tong slide sa creatinine. Para ako na lang i-include. Anyway, ayan, so copper, no? Copper na lang. It will combine with creatinine from the patient sample to produce the copper creatinine complex. All right. Now, this copper creatinine complex will serve as the peroxidase, no? So, peroxide man ni siya, imuhang diisopropyl benzene hydroperoxide. Kaning copper creatinine complex will serve as the peroxidase. So, yung bulagon ning H2O2, napalit chromogen here. Ayan. Okay. So, iyang buhaton is ang copper creatinine complex, iyang bulagon or iyang i-reduce ang H2O2 peroxide, which will now produce water, all right? And ang oxygen na nawala, mabutang sa chromogen. That's why may mo siyang oxidized chromogen. And this oxidized chromogen will now produce the color na makithan, all right? So therefore, the increased color, increase po ng creatinine na okay, that's the principle. So same siya principle sa imuhang blood, pseudoperoxidase activity. So we say pseudo, di ba? False, no? Mura siya nag-assume. Nag-assume siya sa role na peroxidase siya, pero dili yun siya peroxidase. Ganun. Okay? Ayan. So same siya principle sa blood. Alright. Okay. So that's for the albumin-creatinine ratio. And here's an example. Gikan sa Strassinger. As you can see, compare yun siya. Ratio, no? Wait lang. So if negative mo yung protein, negative ang protein, ayan, and 10 lang ang creatinine, it means you need to recollect because it means it's too dilute. Medyo dilute na kayong ihi to produce an accurate result. Because even the creatinine is really low, no? So it means na medyo parang, ayan, it's really diluted. Okay, so you have to recollect. But as you can see, normal yun na mas medyo taas ang creatinine compared to your protein. Okay? And as you can see, if protein increases, bahalag taas yun ang creatinine, no? Then dira na mo signify a normal na result. Because again, taas na kayang protein. Okay? Alright. Bahalag ang creatinine ng taas, in a way, it can indicate lang na medyo daghan or creatinine will indicate na medyo normal lang, no? At least sige nang ga-produce Japon. Okay? Pero kung protein na gani, it could indicate na there could already be initial damage na to your kidneys, all right? Especially sa glomerulus. Okay? All right, ayan. Sige, so that's for your albumin-creatinine ratio. Okay, all right, sige. All right, now we go na to the second, it's still under glomerular proteinuria, dears, your orthostatic or your cadet or postural proteinuria. So this, dears, is actually non-pathologic lang, no? It doesn't indicate really a renal disease, no? It does not point to renal disease, all right? So this happens only during, or it happens during times or states kung asa magtindog ka, no, for long periods of time, no? And it is due down to the increased pressure to renal veins. And because this increased pressure sa renal veins, no, possible na ma-overcome niya ang shield of negativity and the glomerular filtration barrier. That's why pwedeng mo gawas ang imuhang proteins sa ihi, all right? But after standing and then mulingkod na ka, or after assuming, no, a standing position, ayan, mawala na po ng proteinuria. Okay, all right. So that's for your orthostatic, cadet, or postural proteinuria. And how do we differentiate? We use the first morning urine. Of course, for first morning urine of the orthostatic proteinuria, imagine first morning, ikan lang ka naghigda, di ba? Kaya natulog. So of course, there will be no protein found in your urine, negative. Pero after standing for 2 hours, ayan, dito pa siya ni positive. Because again, nanay assuming a standing position or nitindog na ka for long periods of time, which again increases the pressure to the renal veins, all right? Which then leads to the introduction of the protein to the urine, all right? So that is the expected results of orthostatic proteinuria. But if it's really clinical proteinuria, meaning there's already a disease in your kidneys, your glomerulus is damaged already. Of course, sa sugod pa lang, no? In the first morning urine specimen already, you can already see um, uh, in the first morning specimen pa lang, you can already see a positive proteinuria because damage na gini mong glomerulus, bahalag magtindog pa ka dira og 24 hours or muhigdag yun, mo positive yun mo ang ihi sa proteins because again, your glomerulus is already damaged. So asa na specimen mo differentiate sa first morning because in the first morning specimen, negative ang orthostatic proteinuria for proteins and clinical proteinuria is already positive. Kay guba na gyud mismo imong glomerulus or kidneys, that's why pwede na mo gawas ang imong proteins regardless of your position, regardless of any time of the day. Okay? All right. So that's for orthostatic cadet or postural proteinuria. Diba cadet, diba? Mga cadets usually dugay sila mo stand for pila ka hours. Usually, kaning orthostatic proteinuria dears is not exhibited by everyone, no? So, naagya po yung uban lang na mo exhibit. And it needs monitoring, okay? Because pwede siya in the long run, pwede siyang mo progress to a more serious condition. So, it needs evaluation every 6 months, if I'm not mistaken. Sakto ba to sa Branzel? Every 6 months and then a monitoring, all right? Para again, to prevent lang mga serious cases or complications in the future. All right, okay. Now, same siya with pre-renal proteinuria dears. Pre-renal and functional proteinuria. Pre-renal and functional proteinurias dears, they resolve if mawala na ang sakit. So example, sa pre-renal proteinuria, if mawala na ang infection or inflammation, mugamay na po ang numbers of APR. So that's why mawala na po ang proteinuria sa imuhang ihi. Alright? And for cadet or orthostatic, if after pila ka hours o tindog, paglingkod nimo, after pila po ka hours, mawala na po ang protein sa imuhang ihi. Alright? Unlike your clinical proteinuria good dears na bahalag unsay bahalag unsay imong position, bahalag unsay time of the day, naagi protein sa imong ihi. Because again, there's already damage or nanagi problema sa imuhang kidneys, especially sa imuhang glomerulus or even sa tubules. Okay? Alright, so that's for the orthostatic and or postural proteinuria. All right. Now, the last type of your renal proteinuria is tubular. Of course, so ang imuhang tubules ang problema. So, instead of reabsorbing the filtered protein such as your albumin, dili na niya ma-hemo because there's already a problem with the tubules. So, one of that is, of course, the Fanconi's syndrome. And Fanconi's syndrome could be acquired or inherited because of possible damage to the tubules or genetic siya na damage yung tubules. So, the normally reabsorbed na mga substances in the tubules are already excreted in the urine, such as, of course, your amino acids, diba? Remember? So, in patients with Fanconi syndrome, na siya amino aciduria, proteinuria, glycosuria, and phosphaturia. So, na phosphate, no? So, the normally reabsorbed na mga substances are secreted or excreted in the urine. Because again, your tubules are defective in reabsorption. Okay? Another one, another cause is, of course, toxic agents and heavy metals and severe viral infections, which could have altered or damaged your tubules. Okay. Now, what are the major proteins in tubular proteinuria? Of course, albumin pa rin. Pero, albumin, dears, is, iyahang levels is not similar or it will not reach to the levels found in your glomerular proteinuria. Medyo gamay-gamay lang, alright? But it can still be found. It can still be detected, okay? Alright. Another one is, of course, beta-2 microglobulin, alpha-2 microglobulin, alpha-1 microglobulin, retinol binding protein, and lysozyme. So, kanisa na mga proteins, dears, these are normally reabsorbed. Di ba remember beta-2 microglobulin? I mentioned in your renal function. It's a major indicator of tubular integrity, di ba? And the presence of your beta-2 microglobulin, especially sa clearance, di ba? Is indicative of tubular damage rather than glomerular damage because your beta-2 microglobulin is a good indicator of tubular integrity. Okay, all right. Now, the other proteins, of course, these are the normally reabsorbed proteins. Now, in this case, of course, tubular proteinuria, guba imong tubules, so these substances are not normally reabsorbed na hence excreted in your urine. Okay, all right. So, ayan, additional lang, no? What are additional, agikanin siya sa strasa gyapon na parang i-include gyapon what are the causes of renal proteinuria. Ayan, amyloidosis, ayan, because the amyloid can damage your glomerulus, immune complex, as I mentioned, strenuous exercise, dehydration, of course, decrease in fluid, it can increase in your decreased fluid, which can concentrate your urine, so there could be proteinuria. Hypertension, of course, increased blood pressure, which can overcome, no? the glomerular filtration barrier, okay, which can express the protein in urine. You have preeclampsia, of course, seen in patients, pregnant patients, no? So it's exhibited by high hypertension po sa mga patients na pregnant and proteinuria, and of course, orthostatic, as we have discussed. All right. Now, this is from Brunzel. Here's the mga levels of protein in different diseases. So for glomerular, as you can see, higher yun ang levels, no? Greater than 2.5. For tubular, dili ka siya kabot ng 2.5. Okay. For albumin, of course, as you can see, glomerular Japan ang pinakadako, greater than 500. For beta-2 microglobulin, asa siya dako sa tubular disease. Because again, we have mentioned that beta-2 microglobulin is a marker for tubular integrity. And tubular reabsorption of filtered proteins, as you can see, medyo 95 ang normal, pero as you can see sa tubular, 50 na lang. No? So, 45 na excrete niya. So, medyo dako ra gyapon na level. Okay? Because again, I problema sa tubular disease. Okay. All right. So, that's na problema sa tubular disease. Okay. So, that's for the characterization of renal proteinuria. The levels of proteins, no, found in your different types of renal proteinuria, glomerular and tubular. All right, okay. So that's for the glomerular proteinuria or renal proteinuria. Not yung problema mismo sa kidneys. All right. Now we go na to the last type of proteinuria, of course, post-renal. So mas easy lang no to remember or easy lang to comprehend talaga. Post-renal after na sa kidneys, no? So the structures after the kidneys, your bladder, no, prostate, especially for males, and vagina for females, they can introduce mga substances that contain protein, all right, which can lead to proteinuria. So example, lower UTI, no, inflammation, injury or trauma, which can introduce blood, so na hemoglobin, all right, menstrual contamination, prostatic fluid, of course, or spermatozoa and vaginal secretion. So after kidneys, no, post-renal. So easy lang to remember. Okay, all right, kumapit ka dyan. Alright, tatawag sa nako. Okay, so those are the types of proteinuria. You have pre-renal, renal, and post-renal. So therefore, dears, if mo positive yung mga ihi o protein, you cannot really immediately say na, okay, it could be caused by a kidney problem. Although, makaingon jud ka na kidney problems, di ba? As we have mentioned, kay your reagent strips are really sensitive to albumin. Pero you also have to take into consideration no other causes of proteinuria. Base na ba siya pre-renal or post-renal na mga causes. So you have to look at other cases no or other tests no or you could also look at patient history no or other pertinent information para maka-help yun nimo. Okay? To really diagnose in a way, especially if ma-doctor na ka. Alright? For medtechs, of course, dili ta maka-diagnose. Okay, alright. Ayan, sige. That's for the clinical significances of your proteinuria. All right. Now we go to determination, especially for reagent strip, no? So the reagent strip for protein, pila ka seconds? Of course, 60. No, it's part of PAPA-BUN, PAPA-BULAN. All right. And what is the principle? Your protein fluorescence error of indicator. So ano siyang error of indicators? Because you have an indicator impregnated in your pad. All right. And this impregnator, this pad is maintained at a constant pH of 3.0. So acidic buffer. Now, in the absence of protein, the color will remain yellow, okay? But in the presence of protein, mo change na siya og color, all right? Because your protein is an hydrogen acceptor. So, kuhaan niya og hydrogen imuhang indicator. So, what happens mo change ang color, all right? So, instead na ma-maintain ang color, all right? Or at this pH, dapat inani ang colors indicator. At a lower pH noon or nakuha man siyang H plus ions, muna ang murag na error, no? Nasayop na noon niya ang function. That's why it's called protein error of indicators, all right? So since ang protein, makuha man kang H plus ions from the indicator, therefore, ay muhang color na positive kay medyo katunang padulong sa basic. Kay kuhaan man mo H plus, no? Ay muhang indicator, all right? So therefore, the higher concentration of protein, ay muhang color is padulong blue to green, all right? So that's the principle, protein error of indicators, fluorescence error of indicators. Okay, now what are the reagents? Ayan, medyo mataas ang pangalan, pero how do we remember? Credits to Sir Errol, the best, no? Tetrabrom, protein yan. Nako, take note of that. Take note of the sound, no? Tetrabrom, protein yan. As you can see, tetrabrom, phenol blue, tetrachlorophenol, tetrabromosulfontanine. Basta na ay word na tetrabrom, protein yan. Okay, sana naman effective. Tetrabrom, protein yan. Tetrabrom, protein yan. So, muna siya mo remember, sige dears. Tetrabrom, protein yan. Tetrabrom, protein yan. Pwede mo siya gamon o beat, no? Like magamakag beat, tetabrom, protein yan, o, di ba? Or kamo na bahal, alright? Right, really stuck with me until now, no? Imagine, 2019 pa ako nag-review, pero until now, makadungog pa ako sa voice ni Sir Aaron. Sa akong mind, kung akong mabasa ni. So, inaana siya ka-effective. Okay, so, tetabrom, protein yan. Okay, alright. Now, what are the interferences? Of course, false positive. You have highly alkaline buffered, alkaline urine, no? Highly buffered alkaline. Why? Because this alkalinity will override, no? Iyahang i-override ang buffer system sa imuhang reagent pad, which is maintained at an acidic pH. So, iyahang palitan, iyahang sumasapaw, ayan. Iyahang i-override ang acid buffer system. So, therefore, alkaline, di ba? Alkaline man siya, so therefore, ang color is padulong blue-green. Okay. Pigmented specimens which can mask the color, no? Phenazopyridine, which causes pigmented urine or pigmented specimen. Quaternary ammonium compounds, which are basic, all right? Antiseptic chlorhexidine, the loss of buffer, of course, from prolonged exposure of the reagent strip to the specimen. And you have high SG, all right? Because if high SG, medyo, okay, okay. High SG it can override also, no, the system, okay? Okay, and it can also limit the sensitivity of the test, okay, to the protein. All right, okay. False negative is, of course, proteins other than albumin, all right? So, because again, your reagent strip is very sensitive, no, to albumin. It's actually very specific to albumin, dude, all right? Very sensitive siya to albumin because albumin has a lot of amino groups which can accept the H plus ions. So, therefore, medyo, since specific yun siya and sensitive to albumin, medyo hindi na ito ma-detect ang other proteins, alright? Such as, especially those sa mga pre-renal na proteinuria, such as your mga APRs, alright? So, kung false negative siya, could be proteins other than albumin or microalbuminuria, yes, little in concentration pang albumin, and dilute urine. We say dilute urine, di ba? Water is, your protein concentration is affected by water hydration. So, kung dilute imong ihi, so possible po na gamay na lang ang proteins na ma-detect sa imong strip. Okay, all right. Now, notes again, indicator is sensitive to albumin. Albumin yun primarily, all right? Okay, so possible lang yun na dili ma-detect ang ubang proteins because it's really sensitive to albumin. Okay, and correlations with other tests, of course, blood, nitrite, leukocytes, and microscopic. Okay, we look at for the different correlations to other tests. All right, now take note, there's the presence of a trace protein in dilute urine is more significant compared to the presence of protein in a concentrated specimen. Remember, dilute urine, no? So makayon jud ka na dilute urine, so meaning dako kayo ang water concentration. So yung expected is negative na yun ang protein or medyo wala jud kayo ma-detect. Pero the fact that you detected trace, no, small amount ra gyapon, it indicates na intense jud ang pathology na nahitabo sa imong lawas. Kaya imagine, even at that high concentration of water, all right, or high fluid consumption, nagyapoy protein na ma-detect. So meaning possible yun na daghan yung proteins ang na-excrete sa imong lawas. So possible na since daghan mang proteins ang na-excrete, it could only mean na intense na po ang pathology or intense na po ang damage na hitabo sa imong glomerulus or sa kidneys. Kay even, imagine, di ba? Dilute urine, no? Medyo taas imong hydration or imong water content. Pero nandiyan kay protein na makitaan. Di ba? We mentioned that if dilute ang urine, maka-expect ka na medyo negative or negative na binang protein kaya na-dilute na siya. But in this case, kung trace na po na trace, no, na gamay, you could really say na, okay, even at this level of hydration, at this level of dilution sa imong ihi, nadya po kay protein na makitan, it could only point na intense na yun ang pathology or damage na hitabo sa imong kidneys. Kay even, no, at this level of hydration, at taas kaayo daghang water, nadya po yung protein na makita, it could only mean na daghan yung proteins ang makagawas, daghan yung proteins ang nigawas from the filtrate or from the plasma padung sa kidneys because again, medyo guba na gid imong glomerulus or imong kidneys. So I hope nag-get lang to siya. Alright, so the presence of a trace, no, or the result na trace protein in a dilute urine is more significant compared to the positive protein in a concentrated specimen. Okay? Alright, so take note of that. Alright. Okay, ayan. Sige, so that's for protein. Okay. Whew, okay. Alright, sige. So that's for your protein. All right. Now, what are the color changes? As you can see, yellow through yellow, green, and green to blue. As you can see, again, kung mas mo kadaghan na, mas mo darker ang color. All right. Because again, as we have mentioned, kuhaon sa protein, imuhang H plus ions. Okay. So in a way, mahimong mag alkaline, imuhang reagent pa. Therefore, medyo mo darker ang color. All right. So the intensity of the color is directly proportional, again, to the amount of protein found in your urine. Okay. So again, reagent strip DIRSA, it's sensitive to albumin. Okay. Pero other proteins can still be detected, pero primarily albumin gud ang ma-detect. Okay. All right. So that's for your for the reagent strip for your protein detection. Again, the principle as a principle, protein error of indicators. Okay. Na error, no? Nasayop na noon ang imong mga indicator. Kaya nagpabibo si protein. Ayan, sumasapaw si protein. Ganon. Okay, now, of course, if you want to confirm, no, let's say na false negative, no, or negative imuhang reagent strip. Pero the patient history daw is, or may mga patient history of inflammation, infection, or there is patient history of other diseases that could point to proteinuria pero negative siya sa mga reagent strip. So you can perform, of course, other chemical tests, di ba? Classic chemical tests. And one of that is, of course, your SSA, your sulfosalicylic acid precipitation test. Ayan. And this precipitation test is a cold precipitation test, meaning dili mo siya painito, no? You don't expose it to heat, no? You just add the reagents and then wait for the reaction, okay? So once a procedure, 3 ml of your 3% sulfosalicylic acid, SSA, plus 3 ml of centrifuged urine, and then let it stand for pila ka minutes, and then you observe for cloudiness. I think you let it stand for, nalimot ko sa procedure. I think 15 minutes or overnight ba? I'll check ha. But I think mga pila ka minutes to. All right? And then you observe for the cloudiness. Now, what is the grading? Negative is, of course, no increase in turbidity. Trace is noticeable turbidity. 1 plus distinct turbidity. Ayan. How do we remember dears? 1 plus distinct turbidity with no granulation. So, turbidity lang. Turbidity. Your 2 plus turbidity with granulation, duha na, pero walay flocculation. So as you can see, 2 plus, sa pangalan na, 2 plus, duha po niyahang turbidity. Or duha po niyang characteristic, turbidity and granulation. O, diba? So 2 plus. Sa 2 plus, duha po niyahang characteristic, turbidity and granulation. Pag-abot sa 3 plus, tulo na po niyahang characteristic, turbidity, granulation, and flocculation. O, diba? So 3 plus, ayan. And 4 plus, clumps of protein. So how do you remember again? 1 plus, ayan ha, para ma-remember natin. 1 plus, turbidity ra gyud, pero walay granulation. 2 plus, okay, 2 plus, duha po niyang characteristic. Turbidity and granulation, okay, pero walay flocculation. Okay, kay 2 plus ra gyud siya, so dapat duha ra yang characteristic, okay? 3 plus, tulo na yung characteristic, turbidity, granulation, and flocculation, o, diba? So easy na to remember. And 4 plus, clumps of protein. Now, for protein range, always remember lang, mag-start of 6. Less than 6, then 6 to 30, 30 to 100, 100 to 200, 200 to 400, and then finally, greater than 400. Okay? Ayan. So, that's how you remember theirs. Especially sa sa characteristic or description sa mga grading. Alright? So, no turbidity, negative. Noticeable lang na turbidity is trace. 1 plus, 1 plus, 1 plus, usara po diyang characteristic, turbidity. Okay? 2 plus, duha ka characteristic, turbidity and granulation. 3 plus, tulo po ng characteristic, turbidity, granulation, and flocculation. Ako. And 4 plus, clumps of protein. Ako, very easy lang to remember. Okay? Lumalabas sa words, alright? So here's an example here, as you can see, increasing turbidity, and pag-abot sa 4 plus na yung mga clumps na makita. Okay? Alright, sige. That's for your SSA, precipitation test. Your SSA, yung advantage, not really advantage, pero it can detect all proteins you found in urine, not only your albumin. So, kinsa na mga proteins makita sa imong ihi, it will create turbidity. Okay? Because again, you expose your proteins to SSA, which is an acid. And remember that proteins, if exposed to high temperatures or acid, they become denatured. And once they denature, they precipitate. Diba? Ayan. So, that's for your SSA. Again, it can detect all proteins, no, regardless, not only albumin. Okay? All right. Sige, that's for SSA. Okay. All right. Grabe taas sa atong discussions of protein shocks. Okay, all right. So that's for protein. So of course, I hope medyo gets na itong discussion. The major clinical significance good of protein is it's really indicative of renal disease, no? Early indicator good of renal disease, all right? And the primarily detected protein is of course your albumin, all right? And the presence of protein in urine is of course, you can already think now, okay, there is renal disease. But again, as we have mentioned, it can also indicate other causes of proteinuria, not only renal disease, but also inflammations, no, or diseases prior to reaching the kidney, which is pre-renal, or those that are after the kidney, structures that are after the kidney that could have contributed to the protein in your urine. Okay, from primary good, clinical significance good, basta na protein sa ihi, dears, the first thing that should come to mind is there could be renal disease involvement, or there is a possible renal pathology na nangyayari. Okay? So I hope nag-gets lang to siya. So medyo taas kayo ng discussion sa protein. Okay? Parang pila ka minutes. Oh my goodness. Okay. Alright. Sige. Next, we have, of course, your glucose. No? Si glucose naman siya ang pinaka-common. Ayan. The most frequently tested chemical analyte in your urine. Because again, of the advent of diabetes mellitus. Alright. Now, in normal, dears, normal ihi, glucose is little yapon. Parang siya po siya sa imuhang protein, alright? But in diseases such as your diabetes mellitus and renal associated diseases that could have led to the introduction of glucose in your urine, then the appearance of glucose in urine will be high, no? Or the concentration of glucose in your urine will be high, alright? And primarily the appearance of your urine, the appearance of glucose in your urine is highly dependent on its renal threshold, and we have discussed that already. The renal threshold is the concentration, the plasma concentration of a substance at which the tubular reabsorption stops. Meaning, if maabutan ni siya ani, imuhang tubular reabsorption mo ingon na di na ko nimo na I don't want it anymore, no? Moingon jud ang tubular reabsorption ni moingon ang tubules nimo na I've had enough, no? This is enough, ganun. So what happens iyan ang ipagawas ang substance imuhang urine. That is your renal threshold. And for glucose, again, 160 to 180. So if kanina levels, no, greater than 160 na gani, ang imuhang urine, imuhang glucose, plasma glucose, possible na mag-start o gawas or appear ang glucose sa urine. Okay? Now, this is from graph, no? Normal amount of glucose in urine of a fasting patient, as you can see, it's 2 to 20 mg lang per 100 ml of urine. So it's quite little lang yun siya, all right, in a fasting patient. Now, glycosuria is the presence of sugars in your urine. So when you say presence of sugars, glucose and the other sugars, okay? But if it's only glucose, imuhang pasabot na naasa imong ihi, it's of course, ang term is glucosuria. But glycosuria, it takes into account the other sugars found in your urine, not only glucose, okay? Now, what are the other sugars found in your urine? This is from Henry, no? They are all identified by TLC, your thin layer chromatography. Number one is, of course, fructose, or also known as levulose. This is increased in patients who have ingested fruits, honey, syrup, or those that with fructose intolerance. Number two is, of course, galactose. Ayan, galactose is composed of lactose and glucose. Ayan, take note of that. So it's a disaccharide. It's composed of glucose and lactose. All right. So it is increased in infants with galactosemia. Lactose is composed of glucose and galactose. During pregnancy, lactation, strict milk diet, lactose intolerance. Okay. Pentose is increased in benign essential pentosuria, all right? And sucrose is increased, which is composed of glucose and fructose, increased in intestinal disorders or sucrose intolerance. Now, 1, 2, 3, 4, and glucose, dears, they're all reducing sugars. Now, take note, sucrose, which is your table sugar, okay? Kana ang ginagamit na ito pagbutan sa itong mga kape, Milo, and the rest. It's a non-reducing sugar. Take note of that. So, take note of that, dili siya maka-reduce, dili siya reducing substance. Okay? It's a non-reducing sugar, ang sucrose. Okay. Now, take note, dears, among all the other sugars, aside from glucose, the most important or most clinically significant is, of course, your galactose. Okay? Take note, aside from glucose, another important sugar sa imong ihi is galactose. Not really for us, but for infants. Okay? Because the presence of galactose in the urine of patients in the urine of infants rather, indicate galactosemia, indicate a problem in galactose metabolism. All right? And if didn't siya ma-detect, dears, at an early age, especially sa mga infants, it can lead to death, it can lead also to coma, and it can lead to the loss of thrive, o dili mo thrive imuhang infant, dili siya mo dako, alright? So therefore, as early as it is recommended that less than 2 years old sa patient, ilahang urine is gina-screen na for presence of galactose, no? So mo perform sila mga tests to detect galactose, because again, the presence of galactose in the urine of infants indicate a problem in the metabolism of galactose, which is an inborn error of metabolism, ayan, which we will discuss sa mga metabolic disorders in the later part, no, of our lectures, no. So the presence of galactose talaga could indicate a disease, and once galactose is not metabolized well, ang mga byproducts niya, alright, can be deadly to the infant. Okay? Alright. So therefore, galactose and glucose lang yun ang mga important sugars na sa imong ihi. Alright? So therefore, as you can see, ang lactose is made up of galactose. And galactose is also made up of lactose. Alright? So therefore, as early as that, no, if early pag yun ma-detect siya sa infant, so at least ang diet sa infant ma-modify. And remember that milk is made up of lactose, no? So if ang patient or ang infant magtutoy or moinom og milk, of course, ang mga galactose byproducts or galactose products, yes, or ang galactose from the milk will not be metabolized properly. Okay, so therefore, na mga byproducts na toxic to the infant, which can lead to death. So that's the importance of early detection para at least ma-modify ang diet sa patient, ma-modify ang diet sa infant. Okay, makabalo na ka na, okay, the patient has a defect in galactose metabolism, so the patient should not take any food containing galactose. One of that is milk. So therefore, makabalo ng ang parents, no, that this patient or ilang anak should not eat or drink any substances or any food that contains galactose. Ayan. So, diba? That's the importance of early detection. That's why I think maayo jud ang newborn screening, no? That's the one of the advantages good of newborn screening. So, para at least as early as that, maagapan na dayon. Okay, all right. Now, again, what are the different causes or clinical significances of the increase in glucose sa imong urine? Of course, there are two types. Number one, you have hyperglycemia associated, meaning imuhang lawas jud mismo na problema, no? Or imuhang plasma kay increase ng ganyang glucose concentration. So, conditional level, of course, increase ng blood glucose, increase po ng urine glucose. Meaning, niabot na siya or ni-surpass na siya sa renal threshold for glucose. Alright, so what are these diseases? Of course, you have DM. Very important good. The most popular cause of glucosuria is, of course, DM. You have pancreatitis, pancreatic cancer, and mga endocrine disorders. And all of these, as you can see, acromegaly, Cushing, hyperthyroidism, pheochromocytoma, they release hormones that are hyperglycemic. Diba? Remember, growth hormone, ACTH, no? Catecholamines, these are all hyperglycemic hormones. So they induce, no? They induce the increase in glucose sa blood. So hyperglycemia associated. CNS damage, of course, your CNS consumes majority of the glucose, no? So kung na-damage ito, pwedeng mo-leak ang glucose sa imong plasma. Stress, of course, which induces stress hormones, which are hyperglycemic. And GDM, of course, gestational diabetes, no? It's diabetes during pregnancy, of course, which it induces, no, hyperglycemia sa patient. Alright? So very self-explanatory na, dears. Di na kailangan memorize. Okay? Alright. Now the other cause for hyperglycemia is, of course, for glucosuria rather, is renal associated. So imuhang plasma levels of glucose is normal. Wala problema, no? You're eating healthy, no? You're well, you don't have any diabetes mellitus or mga hyperglycemic hormone associated na mga diseases such as mga endocrine disorders na itong i-mention ganina. Pero ang problema lang is magpagawas kaya ka og glucose. Remember that glucose normally is reabsorbed by the tubules. Now, what is the reason nga nung naay ihi or naay glucose sa ihi is naay problema na sa imong tubules mismo. Alright? Because normal naman yung blood glucose, no? Wala siya nilapaw sa renal threshold, pero nagya po yung glucose na ma-detect sa imong ihi. There is already a problem sa imong tubules. Alright? So impaired tubular reabsorption of glucose. And one of that is, of course, Fanconi syndrome. So na-mention na po nato ganina, di ba? Sa tubular proteinuria, you have Fanconi syndrome. So it's a disease in the tubules, again, defective imuhang reabsorption sa proximal tubules. Number two, you have advanced renal disease, meaning na gid siya, na-affected ng tanang parts sa nephron, no? So magliso nag-reabsorb. Osteomalacia and pregnancy. For pregnancy, there is a temporary lowering of renal threshold. So meaning, instead of 160 or 180, pwede siya mabot ng mga 100, no? Lowering, no? So even if normally imuhang glucose levels, pwede gyapon siyang ma-release sa imuhang or ma-excrete sa imuhang urine. Okay? So I hope na gets na. Very self-explanatory na dears, di ba? Ay, medyo, ano lang, di kayo siya complex. I-understand. Kung hyperglycemia associated, taas na yudaan ni muhang plasma glucose levels and ni-exceed na siya sa renal threshold or ni-exceed na siya sa maximum na kaya lang ma-reabsorb sa mong tubule. So therefore, the excess na mga glucose, it will be excreted in urine. Whereas for renal associated, na siya problema sa imuhang kidneys. Okay, ayan, may problema sa mong tubules. Alright, so naglisod na og reabsorb. Alright, okay, ayan. So that's for the clinical significance for glucose. Alright, okay. Now, what is the principle for the reagent strip of glucose? Again, glucose, pila ka seconds? 30. So silang duha ni, of course, bilirubin, silang duha ang shortest reaction to take place in your reagent strip. And what is the principle? Double sequential enzymatic reaction. And if you have to memorize, there's a chemical reaction, okay? From all the reagent strip parameters, I highly suggest you memorize glucose, okay? All right. Highly suggest good glucose. At least man lang ang glucose mo ang ma-memorize. Now, what is the principle? Double sequential enzymatic. Nasa pangalan na, it uses two enzymes, all right? So here is the reaction. Glucose, no? In the presence, glucose oxidase, which is highly specific to glucose, no? Glucose oxidase in the presence of oxygen air, room air, it will catalyze the reaction between glucose and the oxygen air to produce gluconic acid and hydrogen peroxide. This hydrogen peroxide will now be used in the second reaction, which is utilizing the enzyme peroxidase. Peroxidase, no, will again will reduce your hydrogen peroxide, and this reduction of the hydrogen peroxide will lead to the oxidation of your chromogen, all right? And the result is the oxidized chromogen plus water, okay? And this oxidized chromogen will now be detected as a color change. So an increase in the oxidized chromogen will result to increase in color, which indicates an increase in the concentration of glucose. So the more intense ang color, the more intense or the higher the concentration of glucose, all right? Because more na chromogen ang na-oxidize because daghang H2O2 na na-produce, okay, from the glucose found in your sample, okay? So I hope na-gets lang to siya. All right, basta mga peroxidase good dears, ang imuhang enzyme na peroxidase, iyahang i-reduce ang H2O2. So mawala mo sa ka-oxygen. So katong oxygen, mo balin sa chromogen, that's why may mo siyang oxidized chromogen. And this oxidized chromogen will be muna siyang mo-produce a color, alright? And the increase in oxidized chromogen, meaning increase po ng H2O2 na produce. And asa man ka ng H2O2, gikan sa glucose and oxygen na reaction brought about by the enzyme glucose oxidase. Alright? So I hope ma-explain na to ninyo ha. Glucose oxidase, peroxidase, no? That's why it's called double sequential, no? Magsunod ilahang reaction. Enzymatic. It uses two enzymes, glucose oxidase and peroxidase. And this reaction, dears, take note, is highly specific to glucose. So kung mo positive ganin siya sa imuhang urine, then ang na-detect niya is glucose and not the other sugars because this is very highly specific to glucose. All right. Now the reagents, take note, duha ka enzymes, glucose oxidase and peroxidase, and you have potassium iodide and tetramethylbenzidine. So kanis lang chromogen. Dira sila mo differ, no, depending sa manufacturer. So basta ang imuhang basic remember na yun na reagents, dears, bahala kinsa na manufacturer, two enzymes, glucose oxidase and peroxidase. And sa chromogen siya mo differ, imuhang potassium iodide for multi-sticks and chemstrip kay imuhang tetramethylbenzidine. Alright. Now, what are the interferences? Of course, false positive, oxidizing, ayan ako. Basta mga oxidizing agents such as detergents or bleach. Because, remember that siya ang mo intensify, no? Siya ang mo intensify si imuhang glucose oxidase na reaction. So, oxidizing man siya na agent. So, siya ang mo intensify. Elevated uro, it could be when using some automated methods for some brands of strips. It could be na mga interferences in terms of color reaction, no? That's why ma-false positive siya. Kung elevated ang uro. Okay? Take note of that. For false negative, of course, high levels of ascorbic acid. Your ascorbic acid, dears, is a reducing agent. So what happens, instead of ng chromogen, ang imuhang instead ang H2O2 ang i-reduce sa imong peroxidase, ang ascorbic acid doon niyang i-reduce. Okay? So, siya ang nagpabibo. So, masapaw gid siya, promise. Alright, ayan. Okay, pasensya, sorry, mali. Ang H2O2 pala, ang H2O2, dears, iyahang i-oxidize di ay ang ascorbic acid, sorry. Ang H2O2 pala. Instead ng H2O2 yung i-oxidize ang chromogen, ang ascorbic acid iyahang i-oxidize. That's why wala no, hindi na ma-produce ni siya na reaction. That's why false negative. Okay, so instead na chromogen ang i-oxidize sa H2O2, it's the ascorbic acid na i-oxidize sa H2O2. That's why man negative dili ma-produce ni na reaction kaning oxidized chromogen and water. Therefore walay color reaction na ma-produce. Okay. Ketones, of course, which can override or decrease the sensitivity, but this is rare because usually, di ba, large numbers of ketones are detected if ang imuhang impaired diabetes mellitus, di ba? Impaired yung carbohydrate metabolism, all right? Now, generally, in impaired carbohydrate metabolism or in DM, high levels man po ng glucose, no? So, ma-detect kagaya po ng glucose. So, medyo rare lang siya. High SG and which can decrease sensitivity, low temperature, of course, and improperly preserved specimen. Yes, improperly preserved specimen, bacteria will utilize the glucose, which can lead to decreased concentrations. All right. Now, sensitivity, 100 mg per dl. Again, glucose oxidase methods are more sensitive to dilute urine compared to concentrated urine because glucose oxidase methods work best in aqueous glucose solutions compared to concentrated na mga solutions. That's why it's more sensitive daw in dilute urine. Other chromogens that may be used by other manufacturers, you have aminopropyl carbazole or orthotolbutin. Okay, so depende na sa manufacturer kung saan na chromogen niya ang gamiton. Okay, so correlations with other tests, of course, you have ketones and protein. Because again, di ba, protein, diabetic nephropathy, all right, and ketones in cases of diabetic ketoacidosis pa rin. All right, okay. Now, in cases lang na, you maybe think, in cases lang, example, infant, no, ang patient, tapos negative imuhang strip, so, and you're detecting galactose, you can perform, of course, confirmatory or other classic chemical tests. Ay, sorry, wala pa pala. Sorry. Sorry, sabaw na. All right. Sorry. What are the expected color changes of your reagent strip? You have yellow, green to brown, or yellow to green. Depende again sa imuhang manufacturer. So again, the darker the color, the higher the intensity of color, the higher the concentration of glucose. Now for ADA, American Diabetes Association, it recommends quantitative reporting. Okay, alright. Now, ayan, balik na ta. So again, in cases na negative siya yung strip, pero you're suspecting of other sugars in your urine, especially, no, especially galactose, no, in infant na mga patients, you can perform, of course, confirmatory, mga TLC, no, or other specific methods. But you can also perform the classic chemical test, your copper reduction test, or your Benedict's test, or using the tablet clinic test. All right. So the principle, of course, it follows the principle of reduction. No, you're reducing sugars, which one of them is glucose. No, it will reduce copper sulfate to cuprous oxide, which is color brick red. Okay. Now, false positive, of course, katulad po mga reducing agents, no, such as ascorbic acid and uric acid, because again, sila ang reduce sa copper sulfate to cuprous oxide, no, instead of glucose. Kaya reducing agent man po sila. Whereas for false negative, mga oxidizing agents, opposite, no, instead of reducing, ilahang i-oxidize noon. Okay? So dili nila ma-reduce ang copper sulfate to cuprous oxide. So take note, dear, copper oxide pala, sorry, cuprous oxide, sorry. Copper sulfate, copper oxide. Okay. Remember, kung false positive, similar to the test principle. Remember that the principle is reduction. So therefore, ang mga false positive agents, mga reducing agents. So similar. Ang false negative, opposite, mga oxidizers. Okay? So take note of that. Alright, sige. So for the copper reduction test, again, dears, it follows the principle of reduction. So it is, we can detect, again, other sugars, reducing sugars, except for sucrose. Okay, your sucrose is not a reducing sugar. So therefore, your sucrose cannot be used as a negative control, no, or a positive control rather, for your copper reduction tests. Because again, your sucrose is not a reducing sugar. So your table sugar cannot be used, okay, as a positive control. All right. Pero again, the disadvantage lang, dears, is dili nimo ma-distinguish, no, kung kinsa ni na reducing substance, because other reducing substances, aside from sugars, ayan, nandito, can also cause a positive result. So for you to really identify, you need to perform additional tests such as your thin layer chromatography, okay, TLC, okay? All right, so these are the substances that can cause a positive copper reduction test because again, these are all reducing substances. So as you can see, not only sugars, but also other mga ascorbic acid, drugs, and even other mga amino acids or mga breakdown products. Okay, so take note of that. So if you really want to detect kung unsay reducing substance na nag-cause ani sa positive reaction, then you need to perform additional tests. Okay? Like thin layer chromatography. Okay. Now for clinical test procedure, the tablet test for glucose, you have 5 GTTs there, urine, or 5 drops, meaning anadirs. GTTS meaning guttate, Guttae, I think, or guttate. It means drops lang. Yeah. 5 drops of urine plus 10 drops of water plus the clinical test tablet. Okay? Now, in cases of high concentration of glucose or reducing mga substances, there could be a pass-through phenomenon. And this pass-through phenomenon occurs when there is greater than 2 grams per DL sugar is present. So what happens is, ang intense na positive DRs is brick red. Pero this brick red positive result will only happen for a short while and then mubalik na dahil siya sa blue or green-brown, which is the negative. Okay? And this is again due to the high concentration of sugar. No? So to prevent this, instead of using 5 drops, you use only 2 drops. And there's a separate color chart for the 2-drop method. This pass-through phenomenon is due to the reoxidation, no? The reoxidation of the cuprous oxide or copper oxide back to the initial product or initial na copper sulfate or copper lahi na siya na metabolite. Okay, so nibalik siya dito because of reoxidation. It's because of maybe exposure na to oxygen after a long period of time and due to the high concentration po of mga metabolites and high concentration of glucose. Alright, so for use, when you use 2 drops na lang dears, at least medyo parang hindi na kayo siya na nakadaghan, alright, and mas mo last na noon ang reaction. Okay, so to prevent the pass-through phenomenon. Alright, now what is the composition of your tablets? You have copper sulfate, which is the main reacting agent. Remember, di ba? It's copper reduction. Sodium citrate, it eliminates interfering oxygen because it produces carbon dioxide pag sulod or pag react niya sa water. All right. You also have sodium citrate for heat production. All right, because it needs heat for the tablet. It also has sodium hydroxide, which can also produce heat, no, in some of the reagents. As a Benedict's reagent pala to siya. Okay. It has sodium hydroxide. Okay, ayan. All right, so that's for the clinical test procedure. And here is your color chart. Again, lahi ang color chart sa 2-drop. Lahi po ang color chart sa 5-drop method. All right, so that's for the clinical test procedure. All right, now how do we interpret? Summarize na lang. Let's say na ay positive daw na kay case study. Positive siya sa reagent strip 1+, pero negative sa clinical test. So it could mean small amount of glucose pa lang ang naan. Remember that 1+ pa lang siya, so medyo baka gamay pa ang concentration. Now, what if positive siya sa strip, pero negative siya sa clinical test? It could be oxidizing agent, interference on reagent strip. Remember that sa clinical test, kung glucose ang naa-dira dears, sa imuhang pagka-positive sa glucose oxidase, remember that dapat sa clinical test positive po siya. Kung glucose yun ang na-detect. Because remember, glucose is a reducing agent. And your glucose oxidase for the reagent strip method is highly specific for glucose. So kung positive dapat siya sa glucose oxidase, niya positive dapat siya sa clinical test, then that indicates glucose ang cause ana. Pero kung negative sa clinical test, pero positive sa glucose oxidase, it could mean the presence of an oxidizing agent. Remember that the false positive reaction or false positive causes, one of the false positive cause of glucose oxidase or reagent strip is your oxidizing agent. And for clinical test, remember, it's the false negative cause, no, of clinical test is your oxidizing agent. Okay? Now remember, if negative yung glucose oxidase pero positive sa clinical test, then that will indicate the presence of other reducing substances that are not glucose. All right? Or possible interference gyapon could be ascorbic acid. Remember that ascorbic acid is a reducing agent. And in the glucose oxidase or reagent strip method, it is a cause of false negative. But in the clinical test, because your clinical test is a copper reduction method, diba? Similar to the test principle of false positive, that's why your ascorbic acid can cause false positive to your clinical test. Okay? Pero again, another cause is non-glucose reducing substance. Possible na other sugars or other reducing substances. Okay? So that's for your summary. Okay? So I hope na-gets lang to siya. Basta, if glucose deers, dapat positive siya sa glucose oxidase or your reagent strip because your reagent strip is highly specific for glucose and positive po siya dapat sa clinical test because your glucose is a reducing substance. Okay? Alright, that's the expected result if glucose yun ang nasa ihip. Okay? Alright, so that's for your glucose. Alright, okay, ayan. So that's for your glucose. Alright. Okay, all right. So we now continue to your ketones. Ayan, ketones. Bakit so ketone? Charot, charot. Ketones. Alright. Remember that ketones are byproducts. Ayan, byproducts of fat metabolism. Remember that in cases of carbohydrate, no, carbohydrate decrease in carbohydrate intake or decrease in source of carbohydrate, the body will try to compensate for this decrease and look for other sources of energy. And one of that is of course your fats. No, this is gluconeogenesis. Yes. So sa fats, no, one of the byproducts is your ketones. No, because after oxidation, beta oxidation of fatty acids, ayan, they produce acetyl coenzyme A, acetyl CoA, diba? And remember, acetyl-CoA is included or part of the Krebs cycle. Yes, biochem, kumusta tayo dyan? And remember that Krebs cycle is part of glycolysis, of the production of energy, di ba? And acetyl-CoA will from the beta oxidation of fatty acids will join the Krebs cycle. All right. But in cases of intense like carbohydrate source, no, this acetyl-CoA will develop or will accumulate. All right. Now, this acetyl-CoA, kay wala man siya mahimo, no? Or wala siya, if dili siya masulod sa Krebs cycle, wala siya pulos in a way. So what happens is, of course, the liver will try to break down this acetyl-CoA. And this acetyl-CoA coenzyme A, iyahang byproduct is the ketones, no? Or the ketones, the ketone bodies. And all right. And what are the major ketone bodies found in the body? Of course, you have the major three ketone bodies. You have beta hydroxy butyric acid. Okay, beta hydroxybutyric acid or beta hydroxybutyrate, followed by your acetoacetic acid, and finally you have acetone. Okay, so these are the major ketone bodies, no, found in your body in cases of ketonuria. All right. Now the major is 70 is beta hydroxybutyric acid, which is again 78%. No, for the parent yun na ketone is acetoacetic acid. And from the acetoacetic acid, as you can see, diri magsugod, and from here, siya na ang mo-produce sa acetone and beta-hydroxybutyric acid. So it's the parent ketone, it's your acetoacetic acid, okay? And this is the ketone body that is detected by your reagent strip. Although ay mga beta-hydroxybutyric acid is the largest in concentration, all right? It's not detected, okay? I'm not sure nga nung dili siya ma-detect, pero in terms siguro of its stability, okay? As you can see, di ba, ang reaction is reversible. So, possible na ang beta-hydroxybutyric acid is not stable. Okay, so possible na dili siya mo last for a long time for detection. That's why we opt for acetoacetate. In a way din naman, grabe to siya magikan, no? The rest of your ketone bodies magikan sa acetoacetate. So, therefore, in a way, ang presence sa other two ketone bodies, your beta-hydroxybutyrate and acetone, can be assumed in the presence of your acetoacetate. Because again, dira man magikan imuhang beta-hydroxybutyrate and acetone. Ang imong parent ketone is of course acetoacetic acid. Okay, all right. Now, of course, ayan, fats will be the source of energy in cases of decrease in carbohydrate intake or carbohydrate sources para glucose. And the renal threshold for ketones, take note, is unsa man 70 mg per dl. Take note of that, 70 mg per DL. All right. Now, clinical significance, of course, diabetic acidosis. Now, in cases now of intense na DM, uncontrolled DM, ayan. So, of course, if hindi makontrol ang DM, body will revert or will go or will choose, no, to metabolize other substances or other storage materials or storage substances as a source of energy. And one of that is fats. Okay? Insulin dosage monitoring, starvation, of course. Ayan. Malabsorption or pancreatic disorders. Yes. Wala na absorb ang carbohydrate. So maglisod o walay glucose na makuha. Strenuous exercise, vomiting, no, and inborn errors of amino acid metabolism. Vomiting because there's increased loss of carbohydrate also when you vomit. So therefore, walay carbohydrate source, so you produce ketones. Okay, so that's the clinical significance of your ketones. Primarily, good dears, it's for diabetes, no? Especially in cases of diabetic ketoacidosis. All right, okay. An uncontrolled DM. Hala, sorry. Wala na ako na-airy. Pasensya. Hala, okay, pasensya. All right. Now we go to the reagent strip for ketones. Ayan, what is the timing for ketones? 40 seconds. What is the principle? Very, simple. Sodium nitroprusside or nitroferricyanide reaction, also known as the Legal's test, no? Or muna gina-follow sa pang classic chemical test na Legal's test. So what is the principle? Acetoacetic acid, all right, will change, or in the in the presence or in combination with sodium nitroprusside, will produce a purple azodite. All right, it will produce a purple color. All right, so purple ang positive result. And acetoacetic acid, as I mentioned, siya bilang gina-detect sa mong reagent strip. Acetone can be detected if glycine is present. All right. So for reagents, you have sodium nitroprusside and of course glycine. Basta sodium nitroprusside, that's for ketones. Okay. Now false positive, of course, mga phthalate dyes, highly pigmented urine, levodopa, and medications with sulfhydryl groups. For the pigmented urine, of course, it can mask the color, no, interfere, and medications with sulfhydryl groups, it could interfere with your sodium nitroprusside. Okay. Ayan. For false negative, you have improperly preserved specimen, of course. Remember that your ketones are highly volatile, especially acetone, no? So pag tartan sa acetone or pag unpreserved siya for a long period of time, may evaporate ang acetone. Aside from that, ang acetoacetic acid will be degraded by bacteria also. So therefore, false negative. Okay. Now notes again, acetone detected only when glycine is present, and correlations with other tests is of course glucose. Your ketone bodies, dears, are of course normally produced put in the blood, no? In cases lang yun na usahay makulangan tag kaon or wala tayong carbohydrate source para source of glucose. But the normal levels lang in blood is about 2 to 4 mg per dl. Take note of that. 2 to 4 mg per dl ang normal levels of ketones in your blood. Okay? And acetone, of course, in patients na naanay murag diabetic ketoacidosis or increase ng ketones sa ilang blood, it can be detected through their odors of breath, okay? Because acetone is released through lungs, no? Through the exhalation sa lungs. And ilahang characteristic odor of breath is fruity, no? Humot, no? Marashag fruit because of the presence of acetone. Okay? Ayan, all right. And acetoacetate normally, dears, no, in the body is actually the preferred source of energy sa imuhang renal cortex and sa heart, no? Na-shock po ko pagbasa na ako ani sa Brenzel, like, really? But because your brain, imuhang brain mag yun, ang main source kay glucose, that's why glucose gyapon atong main source of energy. But for the other, for renal cortex and the heart, ilahang heart muscle, ilahang preferred source of energy is your acetoacetate. As in a shock po ko, really? That's nice. Okay, all right. Ayan. So that's for additional information about your ketone bodies. Okay. Now, similar to your glucose, of course, napod siya tablet test. You have the acid test. Nasa pangalan, di ba? Acid test. Very easy to remember. Acid test, acetone. Ayan. It contains sodium nitroprusside, of course, the main reagent. All right. You have disodium phosphate, glycine, and also lactose. Lactose is added to enhance color differentiation or to enhance color visualization. Okay, that's the purpose of lactose, and of course glycine for acetone. Okay, all right. But your acid test, dears, is very sensitive for the acetoacetic acid pa rin. Okay, and glycine is added again para ma-appeal po ng acetone. All right. Your beta hydroxybutyrate, your dears, is not detected. Wala gyud paki sa beta hydroxybutyrate. Okay, all right. Now, what are the expected results? No, purple for acid test, as you can see. The darker the color, the greater the concentration of the ketone bodies. For reagent strips, still the same with your tablet, purple yapon. Buff pink to violet or buff pink to maroon. Pero majority kay purple, as you can see. Ayan, purple. So, army ni siya. Yes, parehas may army. Charot. Bakit gusto mo yung violet? Army ka ba? Charot. Check lang. Mga toxic to siya ng mga army steers, no? Okay, check lang. Ayan. So, ganun siya purple. Okay, ganun siya purple. You have positive result kay purple. Alright, so that's for your ketones. Alright. Now, the last parameter for this lecture na part, or for this video, we have blood. Alright. Now, for blood, dears, very important because we are actually detecting three in one siya na mga disease states. Alright, you have hematuria, hemoglobinuria, and of course, myoglobinuria. Now, take note when you say hematuria, nasa pangalan na the presence of RBCs, no? Red blood cells dun mismo. Hemoglobinuria is the presence of hemoglobin in your urine, and myoglobinuria, the presence of course, myoglobin. These three can be detected by the blood strip or the blood reagent pad in your reagents shift. That's why we have to discuss them, no? All right, ayan, sige. Now, we'll start first with the clinical significance, of course, with hematuria, no? For hematuria, of course, sa physical palang daan, you can already see, no? Cloudy red urine. But take note, there's no, your hematuria can be divided into two types. You have microscopic hematuria and gross hematuria. When you say microscopic hematuria, the urine appears normal, all right? But inside the urine, especially sa chem strip na or sa microscopic, you can already see medyo increased amounts of RBCs, all right? Pero in terms of gross appearance, medyo wala pa siya ni manifest, no? Dili pa siya red, it's not cloudy red yet. Gross hematuria, good years, it's intense na good, no? Intense na color, cloudy red na good siya. It could indicate na daghan ng bleeding na nahitabo, alright? Or, yeah, daghang bleeding, or daghang presence na good of RBCs na naha. Or the presence of RBCs is really there, or the concentration of RBCs is many or increased, okay? Gross hematuria, alright? So that's the two types, okay? So it's not necessarily na kung hematuria kay red good siya agad-agad, alright? Generally good kung marked hematuria or gross hematuria, cloudy red good siya, alright? But there are some cases na microscopic hematuria siya, dears, alright? Meaning the urine contains RBCs pa, pero the level of RBCs there are not yet at the level na makitaan siya macroscopically, like gross hematuria, alright? Okay, so what are the causes of hematuria? Of course, you have renal calculi, kidney stones. Actually, the initial finding or the distinct chemical finding or microscopic finding of patients with renal calculi is microscopic hematuria. Ayan, dear. So if na case study, pain during urination, pain in your lower back, pain in the sides of your body, and then painful urination, and microscopic hematuria na press the buzzer. Once it's possible na disease sa patient, renal calculi. Na possible na kidney stones. Alright? Take note of that. Okay. Basta ganin ay pain at the sides, no? Pain at the lower back. Ayan. Tapos, pain during urination, alright? And yung pag sa microscopic exam na ay hematuria, na yung mga RBCs na nakitaan, pero ang physical exam, ang color clarity kay normal lang, pero na yung RBCs na nakitaan sa urine, alright, microscopic, and medyo daghan siya, or medyo elevated, pero di ko siya na nakataas, then that could indicate renal calculi. Nako talaga, dears, press the buzzer. Okay. Of course, next, of course, glomerulonephritis, pyelonephritis, mga trauma, no, to your kidneys mismo. You have tumors, trauma, exposure to toxic chemicals, anticoagulants, and strenuous exercise. So these are all capable of inducing parang mga trauma, alright? Or trauma to your kidneys, okay, or to your nephron, okay, which can lead to the introduction of your RBCs. So as you can see, dears, no, medyo, these are all happening in the kidneys. Remember that your RBCs are big. No, so kung mag-bleed ka sa sulod, alright, or if na kay RBCs, your RBC is supposed to be dili gid siya makagawa sa imong filtrate because they are really big, okay? Dili sila kasulod sa glomerulus. But in case of glomerular damage, ayan, glomerulonephritis, pyelonephritis, inflammation na gyud sa mga tubules, ayan. So possible na permeable na noon sila sa RBCs, that's why makita ng RBC sa ihi. Alright? Next, you have hemoglobinuria. Of course, it's clear red urine. Clear red urine because, again, of the presence of hemoglobin. And usually, this is commonly seen in hemolysis, no? Intravascular hemolysis. So, sa blood vessels palang daan, nag-lyse ng RBCs. And, of course, pag lyse RBCs, sa magawas, hemoglobin. And this hemoglobin will be filtered in the kidneys. Now, what are the causes? You have transfusion reactions, hemolytic anemias, no? Severe burns, infections, or malaria, strenuous exercise, RBC trauma, and brown recluse spider bites. Now take note, dears, true hemoglobinuria, dears, again, true hemoglobinuria is kani mga hemolytic diseases, no? Or hemolytic mga RBC traumas inside lang sa blood vessels, alright? But your hematuria can also lyse, no? It can also lyse, especially sa imuhang prolonged standing sa specimen, which can introduce hemoglobin. But that is not your true hemoglobinuria. It can still it can still be hemoglobinuria, pero it's not true hemoglobinuria because true hemoglobinuria indicates hemoglobin release, no, sa sulod palang daan sa blood vessels in mga hemolytic diseases. All right? Okay, such as hemolytic anemias, transfusion reactions. Okay? Now there was a question again in Schlesinger na murag review question, karang chapter question. Okay? I think chapter 2 to siya. So na student, na batchmate ninyo na ni-ask na ako. Alright? And the question nato kay, which of the following is true about about color of urine, something. And the ninth choice dito na yellow urine indicates high hemoglobin. Red cloudy urine indicates RBCs. Alright? And ang answer daw ni Strassinger kaya katong letter A, katong yellow urine indicates presence of hemoglobin. So if mo lang tawon, of course, makaingon ka na sayop siya. Actually, sayop siya. Because again, na may RBCs producing cloudy red urine. Kato siya, mas specific yun. Pero as I've read, no, para dyan ma-settle nato siya, according to Brunzel, of course, hemoglobinuria, hematuria, dears, same siya sa concept na microscopic hematuria. If the amount is just little pa lang yun, alright? Hemoglobin can be found in your urine, or your RBCs can also be found in your urine in amounts pa lang na little to the point na dili pa sila makitaan na macroscopically. Like, dili pag yun makita na na-change sa color, na-change sa clarity, alright, in terms of hematuria or hemoglobinuria. Pero they are there, no? Naagit sa ihi, pero in low concentration pala. So I think mo to yung point sa Strassinger katong letter A. Mo to siyang iyang gichakto ang answer. Pero if you were to choose, dears, if ako ang pa-answer nato, I will choose katujong RBCs producing a cloudy red urine. Because again, that's more specific. Okay, so if ever mong gawa sa inyong exams in ato, alright, sa Comprev or sa boards, then answer katong RBCs, no? Producing cloudy red urine. Pero if na-choice na hemoglobin producing a clear red urine, of course, then pwede po to siya na answer. Pero if in ato ang situation, I think number 22 siya, dears, sa chapter 2 na chapter question, i-check nyo na lang. If I'm not mistaken, ha? Pero about color sa urine. I think sa physical exam pala, chapter 4 na number 22. So, i-check lang ninyo. Alright? Kung unsay answer ni Strass. But according to sa student na ni-ask na ko, batchmate ninyo, yes, letter A ang answer. Katong hemoglobin in yellow urine, something like that. So, again, possible good years na na-hemoglobin sa imuhang normal color na urine. Pero ang levels nila kay medyo low pa lang. Not to the point na maka-change siyang color to their normal or general color na clear red urine. Okay? Medyo little pa lang ang concentration pero they are there. Present siya sa imuhang normal na urine. So again, ang bottom line lang, there's possible good, no? That there are RBCs or hemoglobin in your urine even if the urine appears normal. Or yung color kay normal na yellow, alright? Or mga shades of yellow. Ngano gani possible? It's because nasa dito pero in gamay lang ng concentration. Ilahang concentration is just little, okay? It will not reach to the point na mo change na ang appearance sa urine to their normal color na cloudy red for hematuria or clear red sa hemoglobinuria. Alright? Okay, but it's really possible. Okay? Ayan. And of course, for myoglobinuria, of course, the presence of myoglobin. Myoglobin is, of course, a heme moiety gyapon, no? Found in muscles, right? And this is released, of course, during muscle injury. So this is seen in rhabdomyolysis, muscle destruction, muscle injury. So ang mga diseases, of course, related to muscles, no? Ayan, so nandito na siya. And of course, pinaka-last dears, akong gi-mention ninyo, cholesterol-lowering statin medications, diba? One of the general side effects of people taking statins or general side effects of statin drugs is rhabdomyolysis. So magsakit ang muscle sa patients, no? Na muscle injury, muscle destruction. All right? Okay. And of course, take note here that myoglobin is toxic to your kidneys, no? The heme portion of myoglobin is toxic to your renal tubules. Even hemoglobin, actually, it's toxic. Pero hemoglobin in greater amounts, dito siya mahimong toxic. Ang myoglobin is really toxic, no? Bahalag, medyo little pa siya. Alright? Okay, ayan. Now, we go now to the differentiation of hemoglobin versus myoglobin. Because take note, both of them, they exhibit clear red urine. Ay mukhang myoglobin lang medyo pwedeng ma-reddish-brown. Even pwede po pink na siya. Pero as you can see, medyo same ragid silang duha. Alright? So how do we differentiate? We have two methods, no? Because again, remember that kanis lang tulo mo, positive kinis na sa blood reagent strip. Pero at least ang hematuria, ihang positive kay na ay speckled na yung mga dots. So later, sa positive results, color changes na reporting. Pero for hemoglobinuria and myoglobinuria, they all exhibit a positive, uniform yun na color. Alright? So, how do we differentiate? We then look at different tests. Number one is, of course, plasma examination. Remember that hemoglobin your myoglobin rather, is rapidly cleared, no? From the plasma, by the kidney. So, paspas iyang filtration. Therefore, it will not stay longer, or it will not stay long in your plasma. That's why ang appearance sa plasma is unsay color? Clear, no, or colorless, or clear, walay color. Pero for hemoglobin, because dugay yung filtration or dugay siya mawala sa plasma, your plasma will remain color red or pwedeng pinkish, no? And that is because of hemoglobin. So that's another um, that's one of the differences. So sa buhaton sa laboratorian, pwede siyang mo-collect no, og sample and check for plasma of the patient. And if the plasma is clear, then the cause of the clear red urine of the patient is myoglobin. Pero if the plasma of the patient is red, so the cause of the clear red urine of the patient is hemoglobin. Okay, all right. Now another test to differentiate is of course the Blandheim's test using 2.8% ammonium sulfate. All right, so it follows the principle of precipitation. Okay, so this is a historical test, medyo obsolete na rin din. Okay, pero you can still, we still need to discuss it. Okay, so the principle is 5 ml of uncentrifuged urine, adani mo siya 2.8% ammonium sulfate. You mix and stand for 5 minutes, and then followed by centrifugation. All right, so what happens is you then check for the supernatant and you test the supernatant for with the reagent strip for blood. No, you test mo siya for blood na reagent pad. Okay, now the principle is that in the presence of ammonium sulfate, it will precipitate hemoglobin out. No, so ang hemoglobin ma-appeal siya sa ammonium sulfate sa sediment. Okay, take note. But myoglobin will remain in the fluid. It will not be included by ammonium sulfate sa pag-precipitate. Alright? So take note of that. So therefore, for hemoglobin, since ang hemoglobin na naman sa sediment, wala na siya sa supernatant, so pag-test nimo sa imuhang reagent strip sa supernatant, if hemoglobin ang cause sa red urine sa imuhang patient, ang supernatant niya mo negative na for the reagent strip. Ngano ganito? Because the hemoglobin is precipitated into the sediment together with ammonium sulfate. So wala na hemoglobin sa imuhang fluid. Alright? So pag test mo sa reagent strip for blood sa fluid, negative na. Kaya wala naman ang hemoglobin dito. In contrast to myoglobin, which remains in the supernatant, alright? So pag test mo sa reagent strip for blood, mo positive siya because the myoglobin remains in your reagent strip. Your myoglobin remains in the supernatant. So pag test mo sa reagent strip, sa supernatant, napaman ang myoglobin dito, positive siya. Or positive siya sa blood na reagent strip. Alright? So I hope na-gets lang to siya. And the most definitive test na yun to differentiate the two is of course electrophoresis. Alright? So samot na sa mga recent times karon na mga evolving and high-end natong laboratory tests and procedures, of course, dito na tamo mo adto, or that's what we prefer na. Because again, it's more accurate and more precise, no? Your electrophoresis. So that's how you differentiate the two. Hemoglobin versus myoglobin. So I hope na-gets lang to siya. Alright, okay. Now we go now to the Roos test for hemosiderin. So medyo na-delay niyo siya, dears, pero I'm sure na ni siya sa imuhang dapit sa early part, no? Now, in cases of hemolysis, dears, intravascular hemolysis, hemoglobin generally is captured immediately by haptoglobin, which is the parang, in a way, the transport protein or the protein that will save hemoglobin, ganun. So hemoglobin and haptoglobin will bind together. And this complex is large enough, alright? So dili gid siya makagawas gyud sa glomerulus in cases of hemolysis. Pero in cases of intense na gyud na hemolysis, if too much na gyud na hemoglobin, possible na siya na magawas na sa imuhang tubules, alright? Sa imuhang glomerulus, and pag-abot sa tubules kay ma-reabsorb siya, alright? And this hemoglobin will denature, no? Or will become ferritin, no, the stored form of, di ba, sa iron, and it will denature to form hemosiderin. And this hemosiderin can be detected also in your urine, kung pwede siyang ma-express sa urine, alright? For generally good guys or dears, basta hemoglobin, hemolysis, no, it will be captured by haptoglobin in a hemolytic episode. But if too much hemoglobin is produced na gyud, possible na masaturate ng mga haptoglobin na naa, mugawas na siya sa imuhang glomerulus, and pwede siyang ma-express na sa ihi, alright? And this hemoglobin can also be reabsorbed in your tubules and become hemosiderin. And this hemosiderin, we can test using your Roos test, alright? Hemosiderin, again, can be seen in urine as yellow-brown granules that can be free-floating or attached siya sa mga epithelial cells or sa casts, alright? And it can be detected by adding ferric ferrocyanide. And ihang positive result kay blue, no? So we examine the microscope, ayan. We examine the urine under the microscope, ayan, and we look for this, no? Mga blue granules naka-attach sa mga cells or casts or free-floating put. And that's positive for hemosiderin. Again, our reagents is 2% potassium ferrocyanide and 1% HCl. Okay. Okay. All right. So again, ang purpose again hemosiderin is from the reabsorbed na hemoglobin from intense episodes of hemolytic episodes or intense hemolytic episodes. Ayan. And it is reabsorbed in the tubules and it is stored as ferritin, and denatured ferritin or maguba na ferritin will become hemosiderin. And kanina siyang hemosiderin na ma-detect either sa urine, free-floating, no, or attached to casts, epithelial cells, or macrophages. Okay, all right, ayan. Now again, what is the reagent strip? Reaction for blood, which is 60 seconds, pseudoperoxidase activity of hemoglobin or myoglobin. Okay, so same siya principle sa creatinine. All right, so in the presence of peroxide, ayan, hemoglobin or myoglobin will serve as the peroxidase. So na siya peroxidase activity, no? So na siya enzyme-like, peroxidase-like activity. Ayan. So yung buhaton is iyahang i-reduce ang peroxide, which will then oxidize your chromogen, and your chromogen will be oxidized to produce a color. So same siya sa second part sa glucose, di ba? Oxidase na method. So inanagyapon siya. Basta mga peroxidase. In this case, your hemoglobin or myoglobin serves as the peroxidase, no? So muna siyang pseudoperoxidase. So pseudo, di ba? Pseudo false or peroxidase-like. So kaning hemoglobin or myoglobin na siya capability to assume, no? Assume a peroxidase na function. Okay? Alright. Now reagents, at sa itong reagents, tetramethylbenzidine. That's what you need to remember, dears. Tetramethylbenzidine. Kaya medyo mataas ang mga pangalan, but take note, basta tetramethylbenzidine sa blood yan. Nako, sa PAMIT Quiz Bowl, last September nilang Earl, Lynette, and Cleo, and Lenos. Yes, hello, dears. Nigawa siya na question, and I was really expecting yun ako na shocks. Kabalo si Earl, Annie. Okay, AUB up na ako. Pero nalimtan, no? Pero sige lang, okay lang. So for blood, take note, there's tetramethylbenzidine. That's what you remember. Basta tetrabrom, kakinsa to, protein. Tetramethylbenzidine, benzidine, that is for blood. Take note of that, okay? All right. Now, what are the interferences? Of course, false positive, strong oxidizing agent. Same na gyapon, it oxidizes, no? Same siya o principle, oxidase or oxidizing. Bacterial peroxidases, example, those produced by E. coli. Menstrual contamination, of course, especially from females na nag-collect of blood, nag-collect of urine during their period, all right? And strip contaminated with povidone iodine, that's according to graph, no? So, contaminated with betadine, it can affect also, maybe similar o principle, mo oxidize po siya, no? Now, maybe you may be asking, or you may be thinking, sir, so if ever gidugo, no, ang patient, and then kailangan siya urinalysis, so dili siya pwedeng mo collect, no? Theoretically, yes, dapat dili yun. So pwede siya mo collect kung wala gyud siya gidugo karon or nag-period. Pero na ibang laboratories na mudawat lang. As long as inote siya, no? Inote siya sa specimen collection or sa result form na the specimen or this was collected during the period of the patient, or patient is undergoing menstrual cycle at the collection, at the time of collection. Parang ganun. Basta inote lang siya. Alright? But at least the doctor will correlate na if the positive in blood ba, if mo positive, is it caused by menstrual contamination or is it pathological ba? Okay? So, inote lang na siya. Pero generally good, theoretically, dapat dili good sila mo collect. Mga girls dyan at mga beshies dyan, mga mga teta, alright? You are not allowed to collect urine if you are experiencing your period, especially if nag-flow, no, sa imong blood. Pero depende siya sa lab, no? Na ibang doctors or labs na mo okay lang as long as inote sa result form or sa specimen collection na it was collected during a menstrual flow or during the period of the patient. Okay, all right. Now, false negative, of course, high SG, which leads to crenated cells. So, dili na ma-detect noon ang mga RBCs, alright, kaya na-crenate na. Formalin and captopril and high concentrations of nitrite decrease sensitivity of the tests, alright. Ascorbic acid, of course, is a reducing agent, alright. So therefore, same gyapon sa glucose, no, iyahang i-cancel out, no, ang peroxidase or ang oxidase na function. So therefore, false negative, okay. Pero at least imuhang mga strips, no, they modified na at least high concentrations good of ascorbic acid greater than 25 mg per dl dito pa siya mo interfere. So ilahang gipatasan, no, greater than 25 mg per dl. And of course, unmixed specimens, especially detecting hematuria. Remember that your RBCs will settle at the bottom of your urine And if you don't mix it before testing, pwede siyang dili ma-detect. Okay? Now for notes, again, uniform green or blue, basta uniform gani siya, no? Like smooth lang color, then that could indicate hemoglobin or myoglobin. Pero if nice speckled, na mga dots, no? Spotted, mottled, dotted, that is the presence of hematuria. Because again, RBCs, pag contact nila sa reagent pad, mulize siya. Okay? And this will lead to the dotted appearance of your pad. If na ay RBCs, intact RBCs na present sa imong ihe. Because again, the intact RBCs, in contact sa imong reagent pad, it will lyse. Okay? And pag lyse nila, muna yung produce a dotted pattern sa imong reagent pad. Myoglobin greater than 1.5 mg per dl, it's associated with patients' risk of developing acute renal failure. So imagine, at this level lang, greater than 1.5 mg per dl, it's really toxic. No? So if too much than that, then it can lead to increased risk of developing acute renal failure. And of course, correlation with other tests, protein and microscopic. If too much hemoglobin dears is present in your urine, it can also be positive sa imuhang hemoglobin. Pero imo positive sa protein. Pero if medyo gamay lang ang blood or hemoglobin na detect, it cannot cause a positive result sa protein. Okay? Remember that your protein is highly sensitive to albumin. Okay? So albumin yun primarily. But other proteins can also contribute. Pero dili kayo na naka-intense compared to albumin. Okay? Alright. And of course, microscopic. Kung positive siya, especially sa hematuria, no? Na yung mga speckled, no? Then you are expected also sa microscopic, you can see mga RBCs. Okay? Intact RBCs. So ang sensitivity sa test theirs is greater than 5 microliters, no? The presence of greater than 5 microliters of RBCs is already significant. Okay? Greater than 5 microliters, iyahang sensitivity. Okay? But it doesn't mean na kung greater than 5 microliters, yan, positive siya sa reagent strip, 5 rapod ka RBCs per feeding mo makita. It could be more. Okay? Ang sensitivity na siya sa test strip. Okay? Greater than 5 RBCs per microliter. Okay, so that's for blood. And what is the expected color changes? Yellow through green to green-blue. Uniform siya kung hemoglobin or myoglobin ang ni-cause sa positive result. Speckled, dotted, mottled if hematuria. Intact RBCs ang nag-cause sa positive result. Okay, all right. So that's all for this part of the lecture. All right. For the last part, ayan, we're going to continue now with the remaining bilirubin, uro, leukocyte esterase, and nitrite, and then ascorbic acid, and then the rest na yun until the end, no? So that's in the third video, no? So, medyo weird. Grabe, that's a mouthful. Grabe, dagan kayo ito siya. As in, na-drain ako sa protein pa lang. But anyway, I hope clear lang to siya ang discussion, dears. If you have any questions, feel free to PM or message me, okay? And I'll answer your question as soon as I can. Okay, so thank you for watching, dears. No, I hope you learned something. All right, and I'll see you in the next pre-recorded lecture. All right, thank you, dears, and keep safe.